Slide.
Oh yeah, don't do like the rehab places.
Rehab places.
Okay, everyone.
Just go to like you go to a hospital for.
Oh no.
I heard Caulfield age.
No, it doesn't matter as long as you go to.
Well, it's not week 2, is it? Okay. So, hi everyone.
Sorry.
My name is Taha again. So this week we're doing the 2013 Women's Health paper. Does not have. Okay. This paper does not have faculty released answers. Hopefully. And it also has radiation to the carotids. Okay. Otherwise, they're very similar murmurs, and it's otherwise hard to tell them apart. Okay. So then the next one, let's talk about peripheral pulmonary stenosis. So was this on the list? I'm pretty sure. Well, it was on a list. It's been on a list before, so it's important to talk about. What is the difference? Just in one sentence consisted of 5 or 6 words. What is the difference between pulmonary stenosis and peripheral pulmonary stenosis in the classical sense? Remember, quick answers would be appreciated because we've got so much to get through. Anybody there? So pulmonary stenosis usually refers to stenosis of the pulmonary valve, okay? So it's usually pulmonary valve stenosis. Peripheral pulmonary stenosis is referring to stenosis of the pulmonary artery, okay? So there's quite a big difference there. So what you hear...
Sorry, is it venous tongue the same as a flow murmur?
Mackley?
What?
Is a venous tongue the same as a flow murmur?
Well, there's various types of flow murmurs. Like stills and venous tongue are like types of flow murmurs, if I'm not incorrect.
That's what I thought too.
Yeah,
so I thought flow murmur was just the umbrella.
Table chart. There's like 5 or 6 different flow murmurs. One of them is still, one of them is venous tongue, and they're kind of different.
Okay, so the biggest difference between peripheral pulmonary stenosis and pulmonary stenosis is one is stenosis of the artery, one is stenosis of the valve. Okay, so the peripheral pulmonary stenosis is either usually due to an isolated incident, okay, or it's associated with something, and in this case, it has a heavy association with Alagille syndrome. Okay, so Alagille syndrome, if you remember, has a classical triad associated with it. Can anybody tell me what the triad consists of? Yeah, butterfly vertebra. What else? Bile duct what? Paucity?
You just need to read it.
Yeah.
Or none. No bile.
Okay. And what's the third one?
This one. What is this?
Yes. So pulmonary stenosis. And now you know that's more usually pulmonary artery stenosis. Okay. Now, and yeah. Okay. Now, another thing is that so isolated, associated with something, and it's also often physiological. So in infancy, when you're still trying to form proper pulmonary vasculature, just that alone, having increased pulmonary resistance, can cause a peripheral pulmonary stenosis, a functional one. So you can also hear pulmonary stenosis type murmur in those situations as well during infancy. All right. Now, we'll go through the rest quickly. So pulmonary stenosis, we already know that it's going to be at the pulmonary valve because it's a systolic valve. You're going to hear a systolic murmur, which is harsh. Aortic stenosis, much the same. Coarctation, so you want to listen between the scapulae. So between at the back, that's where you're going to hear the most sounds. And it's usually a continuous murmur because remember, the aorta looks like this. In diastole, the aorta expands. So remember 1/3, it was something like 1/3 or 2/3 of the pressure of systole goes into actually stretching the aorta so that during diastole, when there's no heart contraction, you can maintain the blood pressure. Do you remember that? Yeah. So that's why you're going to hear a continuous murmur with coarctation. And ASD, VSD, we'll talk about those. What is this? Okay, let me clear. So what do you think this is, this picture? Yes, exactly. So this is peripheral, because what is it? What can you actually see? Of the pulmonary artery, yeah? So this is a peripheral pulmonary stenosis. So you see the lesion is there rather than of the pulmonary valve. Okay. All right. So we're still going to be talking about murmurs, but in this case, we're not going to be talking specifically about ASD and the key feature or the key characteristics that you hear in an ASD. So who can tell me, if you're going to describe an ASD murmur, what would you hear? What are the key features? Okay, guys. Yes, systolic. Anything else? Anybody else? Remember, any quick answers would be very appreciated today. Yes, okay. Fixed. What other than the fixed, what else is it described as? The splitting. Wide? Okay, fixed and wide split. Okay. Now we're going to be talking about both of these because it's important to understand. Well, I don't know if it actually is important to understand, but it's helpful regardless. Okay. So we're going to be talking about splitting first. So splitting, so a split S2. So that's what it's referring to. So S2 is referring to the systolic component of the heart sound. What is the systolic component made up of? For which valves? Yes, aortic and pulmonary. Okay. So splitting of the S2 is a normal thing that you should hear during inspiration. All right. So we're just talking about inspiration, okay? Because it's different during expiration. So there's a few key things that happen here. One, and let me get a different color. All right. So one, the chest wall expands. Okay. So when you're taking a deep breath in, your chest wall expands. What is the significance of that? That increases intrathoracic pressure. That's what ITP refers to in this situation. So it increases intrathoracic pressure, which essentially means that it's a vacuum. Okay.
It decreases the thoracic pressure.
So yeah, my bad. So decrease intrathoracic pressure, forming a vacuum. So if you think of a vacuum, if you think of your Dyson at home, it sucks things up. Okay. So first step. So second step. So the reason I wrote increase was because I wanted to write negative pressure. That's what I was referring to. So negative. So decreased intrathoracic pressure means an increase in negative pressure, right? Okay. So the second step. So having an increase in the negative pressure, that allows the lungs to expand, lung to expand, etc. Okay, second step. All right. So third step. So while all of this happening, what also happens is there is an increase. Three. There's an increase. This again. 3. So there's an increase in venous return into the right atrium. Okay. So because you have a negative pressure within your chest, it's sucking all of the blood. It has a pulling pressure. So that's pulling the pressure from things like your SVC, your IVC. And when you're also taking a deep breath in, you're usually compressing your abdominal, well, not one to a certain degree, and that's causing the blood to return to the right atrium. Okay. All right. And because it's also going to the right atrium, which is here. Yeah, that's right atrium, isn't it? No. Right atrium and right ventricle. Okay. Right there. Right atrium, right ventricle. So increasing venous return to there. All right. Then, this also explains why during inspiration, it's normal to have 10 millimeters of mercury difference in your blood pressure. Okay. So you guys might have heard of pulsus paradoxus, right? You've heard of that term. So pulsus paradoxus is when that pressure is greater than 10 millimeters of mercury. So it's normal to have a drop of at least 10 millimeters of mercury during inspiration. Well, the thing is more than 10. So physiologically, you can have a difference of 10 during inspiration because of this reason. Because you're expanding your chest cavity and the blood is being sucked into there, you have that difference in your blood pressure. Okay. All right. So that's third thing. So increase blood to the right atrium and the right ventricle. And then at the same time, this is happening. There's a decrease amount of blood that's returning to the left atrium. Okay. Now the reason for that is, remember, the blood wants to stay inside of the lungs rather than go to the left atrium because there's that negative pulling pressure there. So that blood is being pulled into the lungs and it's not going to the left atrium. So you have one thing, you have increased blood that's going into the right side, and you have decreased blood that's going into the left side. So keep that in mind. So now, because remember, we're in inspiration, and because there is an increase in blood volume in the right ventricle during inspiration, the pulmonary valve, so as it goes up here into the pulmonary arteries, so as it's going up here, so as the right ventricle contracts, there's more blood in the right side of the heart. As it goes into the pulmonary side, it takes longer for the pulmonary valve to close. Okay, so increased blood in the right side, so that increases the time for pulmonary valve to close. Okay. All right. Okay, and the reason for that is because there's an increase in the ventricular emptying time, just because there's more fluid there. So that's number 5. What should I write number 6? I'll write number 6 up here. Okay. Now, at the same time this is happening, the aortic valve, it closes earlier. Okay. It closes earlier because there's less blood volume there. You guys following so far? Okay. So this means, so the significance of this means that during physiological respiration, during inspiration, the aortic valve closes first, and then after a short time, the pulmonary valve then closes. So it follows each other along. First aortic, and then pulmonary. So that is physiological. It's normal for that to happen during inspiration. Now, during expiration, the same thing isn't happening because you don't have that negative intrathoracic pressure. All right. So let's clear all of that. Now we're going to talk about ACT soon. But if I was to summarize it, so we have chest wall expansion. So this is the too long didn't read version. So chest wall expansion during inspiration. Okay. Then we have negative pressure. And then we have increased venous return to right atrium and right ventricle, and decreased to left atrium and left ventricle. Okay, that's great writing, isn't it? All right. So that's the too long didn't read version. You guys understood that? Okay. So now we're going to be talking about the pathological split. Okay. So the pathological split. All right. Let me get a different color this time. All right. So, so what happens? So why do we call it wide? Okay. So we have a wide split. So the wide split means something that is going to further delay. So So further delay the right ventricular emptying time. So remember we talked about the pulmonary sound comes later because it takes longer for all of that blood to empty outside of the right side. So anything that causes that to go for even longer will cause a wide splitting of your S2 component. So things that will cause further delay is something like pulmonary stenosis. All right, that means it'll take longer for the pulmonary valve to close. So that's wide. And how about fixed? Okay, so in fixed, what this means is that the split does not change. So it does not change with respiration. So normally, that physiological split should disappear with expiration. It should be there with inspiration. But when you have an ASD, it's present there for the whole time. Now, there's a reason for that. Because in an ASD, you have blood that's going from the left side of the heart to the right side of the heart. Okay, it's going this way. It doesn't matter if you're in systole or if you're in diastole, there's always going to be more volume in the right side of circulation. So you're always going to have a fixed split. So fixed means that even when you're doing an expiration, that splitting does not disappear. All right, so does that make sense? So that's why you have a wide fixed split A2.
But you said like normally you have more blood in the right atrium and left atrium when you're inspirating. Then should the blood go from the right atrium to the left atrium?
But the thing is that remember the right, even though there's more blood return, there's more venous return, the left side of the heart is still at 120 millimeters of mercury, whereas the right side of the heart is only at 20. Okay, so the increased pressure moves the blood from the left side to the right side. Okay, all right, so that's the first one. So the second one is now we're going to be talking about why, well, you guys can probably understand now why there's a systolic murmur. Can anybody explain why there's a systolic murmur? Yeah. Yes, because you have pulmonary stenosis, you have increased blood flow to the pulmonary side of the circulation, so you hear systolic murmur. Okay, does that make sense? Very good. Okay. So now let's talk about PDA and the murmur you hear there. So tell me, what is the ductus arteriosus?
The embryo was the connection between the pulmonary arteries and the aorta.
Yeah, okay. So pulmonary artery to aorta. Or is it the other way around? Anyway, doesn't matter. Okay. So normally, physiologically, what should happen to the ductus arteriosus?
Should close by itself after up to like 2 to 6 weeks of life.
So usually a day 2 to 3. Okay.
It's the when it was closed, but it continues to close.
Okay. Are you sure?
Yeah, it's like about 80 to 90% closes up.
Okay. All right. Well, okay. Well, typically, then you'd expect the ductus arteriosus to close by day 2 to 3. Okay. So that's a physiological process. However, in some people, that duct can stay open for longer. Who would that be? Premature babies. Okay. So in prematurity, so in prematurity, you have essentially you have a PDA. Now, what's the reason for that? So to understand that, we have to understand how the duct closes normally, okay? So normal closure. So normal closure of the ductus arteriosus is based on a few things. One is removal of the placenta, okay? Because the placenta produces what? Prostaglandins, okay? And prostaglandins is what keeps the duct open. So if you remove the placenta, you remove the prostaglandins. Second thing, okay? Oh, this is not useful, is it? So lung expansion, okay? So that's important because lung expansion is responsible for metabolizing, so metabolizes prostaglandins, okay? So once your lungs expand, or once you're out of your mum, then that is required for you to metabolize all those prostaglandins that are still circulating within your body. So that's the second thing. All right. And the third thing is you have an increase in oxygen tension, which means the oxygen saturations are getting higher and higher, okay, with the onset of normal respiration, and that further adds to getting rid of those prostaglandins and closing the ductus arteriosus. All right. So so what would be pathological? So pathological, something in this process is not occurring, it stays open for whatever reason, and there, and in those situations, you're pathological. Okay, and very similarly, you're going to have blood that's coming from the aorta. Okay, so coming from the aorta, and it's going to flow down back into the pulmonary vasculature So it's also going to cause pulmonary hypertension, pulmonary congestion, and you might hear very similar sounds. But usually what they describe it as is what? A machinery murmur. I still am not 100% sure what a machinery murmur means, but that's what you will likely hear. Okay. So based on understanding the normal closure of the ductus arteriosus, how do you think we would keep it open? Yeah. Okay. Okay. What am I want to ask? How do you keep it closed? Sorry. Yeah. So NSAIDs. Okay. So NSAIDs will inhibit. So remember, because NSAIDs are a COX inhibitor, and COX pathway has prostaglandins. So this inhibits the prostaglandins. And what else can we do? Remember, that was only one of the things. What was another thing that caused the duct to close? Sorry, ductal physiological close. Remember, there was removing the placenta, there was expansion of the lungs, and there was oxygen tension. So therefore, we can give them oxygen. So oxygen at the same time can also help you to close the duct. Okay, all right. And the last thing is, so we talked about physiological closure. So then the last question to answer is, so why stay open in premature? Can anybody answer that question? So in premature infants, so they have very immature lungs, okay? So immature lungs, so therefore they ineffectively metabolize prostaglandins. So that is the reason why someone with prematurity often still has a patent ductus arteriosus. Make sense? Very good. Okay, and then just to talk about these last ones, so for example, VSD, it should be relatively straightforward. You have a connection there. So that means that whenever the heart squeezes, you're going to hear the sound during the whole of systole. Yeah, that's what hollow means. So hollow means during the whole thing. Okay, so now finally we can answer the questions. We finally got to question one. Yeah. Okay. So acyanotic, instantly what can you rule out?
Cyanotic conditions.
Which are?
Yeah.
Okay. Tricuspid, truncus, TGA, TAPD, tetralogy. Well, is that going to give you cyanosis? Tetralogy? Yeah, depends how bad it is. Anything else there? Is there anything else? Okay, very good. Let's continue. History of poor weight gain, tachypnea, and he has the loud pansystolic murmur. Loudest of the left sternal edge. So what is located at the left sternal edge? Left sternum?
Yeah.
Yeah, septum. Because it doesn't really tell us whether it's upper or lower or what. No. What do you think he has?
The right side of the heart.
Is it? Okay, 1 second. I can solve that, I hope. Oh. Okay. Well, it's all right. We only got to the first question, right? But they missed all the other important stuff. Okay, just for the people at home. Okay, I'm very quickly going to re-explain what we just talked about. Just in 1 minute, okay? So we were just talking about murmurs for everybody at home. So peripheral pulmonary stenosis. Oh, that's peripheral. This is helpful, isn't it? So peripheral pulmonary stenosis is artery, not valve. We talked about ASD, and you can read up about it on Wikipedia on what a fixed split S2 is, and we'll leave it at that. Okay. So cyanotic condition. Is it working now, Matt? Very good. Well, they got to see my hair for the whole time. All right. All right. So what is the condition? Okay. Now somebody explain to me. Say you were in an auscultation, and we got an auscultation on potentially VSD/TOF last year. So explain to me why my baby is getting breathless. Sorry? Well, yeah, but we didn't know which one it was, just a VSD alone or it was a TOF. Anybody know?
It's pansystolic months.
Okay, so I have a hole there, right? All right, so what happens is that so I won't call it ventricle, I'll just call systole just for simplicity. So during systole, if I have a big hole there, some of the blood from the left ventricle, and we call this the right ventricle, so it leaks in to the right ventricle, and it passes through the lungs. So I'll draw the lungs here, even though that makes no sense. So it passes through the lungs, it goes to the lungs, and it via the pulmonary veins and back into the left atrium, essentially. Okay. So what happens is that I have an overload. Okay. So it's a reflux that's happening on a circuit, and that causes volume overload in the left ventricle. Okay. So the blood is going here, then it's going back through the lungs, and then back again into my left atrium. So I have overload in my left ventricle. All right. Now the left ventricle has a much higher pressure than the right side. So 120 versus 20 on the right ventricle. Okay. So what happens is that as this progressively occurs, as we have more and more leakage into the right ventricle, this pressure starts to increase. So we have increase in right ventricular pressure. All right. And what that causes is pulmonary hypertension. Okay. So pulmonary overload causing pulmonary hypertension with its associated symptoms. So what are the symptoms of pulmonary hypertension? So we'll write it here. So pulmonary hypertension. So if a VSD is severe enough, what happens is we get cyanosis. Okay. Now, why do we get cyanosis? Because the blood is bypassed. So blood is bypassing the lungs. Okay. So blood is bypassing the lungs. Okay. And if blood is bypassing the lungs, you don't get oxygenation. And therefore, you get cyanosis. So when a baby is feeding is a process where you have a high metabolic demand. They're sucking, they're using their muscles, etc. So the heart is pumping faster. So you get more and more volume overload, more volume coming back to the left atrium, which is eventually going back into the right ventricle, which is overloading the pulmonary circulation, and you can no longer oxygenate the circulating blood. So that is why the baby eventually, especially when they're feeding, they start to become breathless, they start to get tachypnea, and they get more and more poor feeding, and they have failure to thrive in infancy. Does that make sense? Okay, very good. Oh, I did have a picture. Okay, next one.
Very preterm.
Very preterm. They're only 6 days old. Newly appeared murmur. Increasing ventilatory requirements.
Yeah.
Why do they have increasing ventilatory requirements? Because it's a left to right shunt, right? Okay, so what do they have? They have a PDA. So they have a PDA. Very good. Oh, I do have a picture. Okay, next one. So Down syndrome, failure to thrive, a large systolic amount. What do they have? But how do you differentiate that from a VSD? Other than that, okay. Okay, well, think about it, right? So normally, what is the natural history of an ASD and a VSD? What is the natural history? Both of them are typically asymptomatic, okay? So in this case, you have connection between every chamber of your heart. You have 4-chamber involvement. So it's usually in infancy, especially with smaller defects, it should be asymptomatic for your whole life, if not until you're an adult. So this patient is presenting only when they're very young, at 2 months old. And that's because they have connection on both sides. So AVSD, other than being associated with Down syndrome, that is another way to explain it, because they have 4-chamber communication.
Deeply cyanotic.
Okay, deeply cyanotic, 3 days of age, respiratory distress, but no murmur. What do you think they have? TGA? Why do they have TGA? But what is the significance of this? Yes, okay. So well, I wouldn't say, you can't call it a PDA closes, because that would be the opposite. Yes. So the DA closes. So physiological closure, remember, the DA is at 2 to 3 days. So a TGA requires you to have a PDA to stay alive. After the ductus arteriosus closes, you need a VSD to stay alive. Okay. Otherwise, the baby is going to die, because they don't have any connection to their lungs to be able to oxygenate that blood, which is why you require VSD to be alive. So this baby is suddenly at 3 days old, is suddenly becoming respiratory distressed because they no longer are able to oxygenate that blood. So normally what would happen is the blood would go through the ductus arteriosus, then to the lungs, and then back into the heart, and give the baby some kind of oxygen. Okay. All right. All right. Now we're finally on to our second set of EMQs. Okay.
HSV.
Say again. I'm just going through the papers. Okay. All right. 7. HSP. What is HSP?
IgA vasculitis.
Yes, IgA vasculitis.
The holy triad of the non-blanching rashes on the buttocks.
Yes, okay, what is the triad?
Abdominal pain, joint pain, and buttock non-blanching rashes.
Okay, okay, and purpuric rash. Okay, purpuric, non-blanching. Yeah, that's what I'm about to say. Okay, all right. So look at this list and just end there. Just look at it. No, okay. So we're going to go through common exanthems of childhood. Okay, exanthems. So this is the first case, and it's just going to be very simple, straightforward, just what you need to know. Okay. So this man, he has these on his trunk and on his back. He has these vesicles, as you can see here. So there might be fluid filled. So what do you think he has? Chickenpox. Okay, so this is varicella. So what you see here, so timeline, what this timeline refers to is how they present usually, and these are just symptoms that you might expect them to be, expect them to have. So usually it begins on the trunks and then it spreads to the arms and legs. So that's called centrifugal spread. So starting on the trunks and then spreading out to other limbs of your body. So that's centrifugal spread. All right. And then, so after you have these, so you have these, you just start with these pruritic lesions, and then that becomes vesicular, okay? And it forms fluids, and eventually you'll have a crust forming. So the importance of that is that you're not allowed to let them go to school until the crusts have formed, because that's the infectious period. So after they're crusting, they can go back to school. Now, if you have congenital varicella, it's very different. So usually infectious period is less than 20 weeks old, and that is the worst time. Otherwise, it's good. Other important things to remember about varicella is that it will reside for the rest of your life where? Yes, in your ganglionic neurons. Okay. All right. And a major and a very common complication is to have bacterial invasion. Okay. Oh, that's not helpful, is it? So bacterial invasion. So after they have crusted, or once you get the vesicles, you're breaking that skin barrier, so you can get staph and strep infections. Okay. Now, what do you give them? Usually you give them, especially if they have shingles, if they have pain, you can give them some topical lidocaine, but otherwise, if it's indicated, you can give them famciclovir. All right. Is there anything else? Okay, very good. So varicella. So next, moving on to the next one. So you should be able to tell what this is from this symptomatology. Anybody know? Yeah, myringitis. Yes. So it's just inflammation of the ear, of the tympanic membrane. Okay. So yeah, legit. So look at this timeline. So this timeline should tell you what this condition is. So high-grade fever and coryzal type symptoms. Then after 24 hours, they develop this macular papilla. So you can see it's covering the whole body. Soft pink rash. Okay. That starts on the trunk and then it spreads to the limbs. It's not scarlet.
Is it German?
So there's not many things that are going to cause a sudden high temperature. There's only really one childhood exanthem that causes a sudden high temperature. So high being usually greater than 40 degrees. So this is a roseola. Okay. So roseola is due to what? HHV6/7. Okay. So usually incubation periods of 5 to 6 days. High fever is an important part. Most common complication is having myringitis. So what the MCQ might say, or the OSCE will say, is that the child is pulling at their ears and they appear irritable. And it usually resolves, so after the incubation period, it resolves usually within 2 days. Okay. And another very common, so complications, we talk about myringitis, but the most common complication is very logical. They have a very high temperature. So what are they likely to have? Febrile seizures. Okay. So febrile convulsions. So that is a known and common complication of having roseola. Okay. And because it resolves by itself, it gets better by itself. There's no specific treatment that you need to give them. Okay. So going on to the next one. So this is really the most important part, bone marrow related symptoms. Okay. So this condition, long incubation, so usually 6 to 18 days incubation period. So you get infected nearly 2 weeks before you actually start to show symptoms. Okay. I'll give you a bit of history about this. So the first time this was actually associated with human disease was in 1981, when it was actually associated with an aplastic crisis. Okay, and that was in the patient with sickle cell disease. So this patient with sickle cell disease, they got infected with something, and then they had an aplastic crisis. If you get infected with it in pregnancy, if you're a pregnant female, it can cause spontaneous abortion due to hydrops. Why do babies get hydrops? What is the underlying pathophysiology there? Fetal anemia, okay? So something that is causing anemia is something that resides in your bone marrow, something that can cause an aplastic crisis. Does anybody know what it is? Parvovirus, okay? Now, why does it cause all of these anemia slash bone marrow symptoms?
Hormone suppression.
No. Well, yes, but what I was trying to get at is that the incubation, or where it actually replicates, is inside of the bone marrow, okay? So parvovirus, I don't know if replicate is the right word, but that's where it lives. Maybe proliferates, yeah. But what I'm trying to get at is it lives in your bone marrow, so that's why it causes suppression of the erythropoiesis and why you get these anemic type symptoms. It's very important to know that about parvovirus. Okay, now otherwise, you develop, if you get a parvovirus infection, you develop a rash, okay? Now there's 4 rashes that are present here. The first one is the malar rash. So what you notice is these rash on the cheeks, which we call slap cheek, okay? And I'm not sure if you guys remember this from another week when I told you, but you can also get this. So what do we call this? So this is a rash in the glove and stocking distribution. So that is another common way that parvovirus can present. So glove and stocking. And the important thing about this is that it's painful. Okay, it's painful, and it's also purpuric. Okay, as you can see that, you can clearly see that's a purpuric type rash right there. Okay, otherwise, what we see here is just a pink, lacy, so it's pink, lacy, a reticulated rash. Okay. Well, oh, that's helpful. Okay, so that's really what you need to know about parvovirus. Slap cheek, glove and stocking causes bone marrow suppression. Okay? Okay, number 3. Okay, number 4. So, what's this? So really, I mean, this one is also non-specific unless you look at the distribution of where the rashes are. So hand, foot, and mouth disease is due to what? Coxsackie.
Yeah.
It's not just Coxsackie, but it is the most common one. Okay, so usually the child will be 2 to 5 years old. Oh, I forgot to do that for the rest of them. But anyway, fever usually for 2 to 5 days post. Okay, post. Remember, that's why I have this timeline here, because it will help you to identify what it is on an MCQ. Okay. Yes, post the fever. Okay, so they develop the rash post fever. Okay, so they get fever. 48 hours later, then they get the rashes appearing. Okay, so they get rashes on their feet, these vesicular rashes on their hands, and these painful oral lesions inside of their mouth. So because they have painful oral lesions, what is another symptomatology you can expect? No?
Not eating.
Yes, decreased oral intake. Okay, very logical. Okay, now after they get the rash, they are no longer infectious and is self-limiting, therefore there is no specific treatment. Okay, yeah, but in total, it's usually 7 to 10 days of illness. Okay, next one.
Wait, can we go back to this?
All good?
Is it like an example?
It's just a coryzal symptom.
Like a cold?
Yeah, coryzal symptoms. Fever, headache. Okay, so this one's important. So this condition has lymphadenopathy. You have a prodrome of coryzal symptoms, much like many things do. But then after that, you have a rapidly progressive rash. So it starts in one place, and within one day, it covers your whole body. Does anybody know what this is? It's very similar to measles. This is actually rubella. Okay. Now, what's important to remember about rubella is that, so we'll say a rash. Okay. So 7 days before and 7 days after, this is the total infectious period, which is why it was so disastrous back in those days when we didn't have vaccination against it. So before you actually showed symptoms, you were still infectious with the condition. Okay. Now, if you get it in the pregnancy, which is very rare these days, but if you did, it might cause a miscarriage, might cause death, or if you're born, it'll cause your classical blueberry muffin rash and such, heart defects, intellectual disabilities, etc. So how do we, sorry? Yes, PDA, so congenital heart defects. So how do we detect it in pregnancy? What do we need to do? So we need to do IgM/IgG for the rubella antibodies. Okay, after they're born, we give them the MMRs to make sure that they don't get rubella. And when do we give it to them? 2, 4, 6. Okay. Do we give it any more after that? I feel like you give it a 12, but I'm not sure.
I think so. What the whole semesters?
Query 12. Look
Yeah,
it up.
12. No, and 12.
Okay, and 12.
Because that's when you also give the other
Okay,
other one.
very good. Okay, so this one, like it, the rash, there's a reason. So this is called morbilliform rash, I believe, which means measles-like in appearance, which is why rubella looks very similar to measles. Okay, so that also looks much like rubella, but there's a few different things. So people with this condition very commonly present with cough, coryza, and conjunctivitis, which is why it's called the triple C. Okay, so what is this? This is measles. Okay, so this is measles. So conjunctivitis up here. So we can see complete redness because remember the conjunctiva is covering the eye. Okay, these are actually called Koplik spots, which are these are called an enanthem. I can't remember what the difference between enanthem and exanthem is, but it's an enanthem, and it is white rice-like spots in the mouth. So Koplik spots, and then this is some very similar rash to what you get in rubella. Okay, so again with our timeline, and this timeline is very important this time. So malaise and fever, so coryzal type symptoms, much like everything else, but then this is important. So how does the rash spread? Usually starts on the face, and then it spreads to the neck, the trunk, and extremities. So compare that to other things like roseola, where we said it starts on the trunk, and then it spreads to the limbs. This one starts on the face and the neck, and then it spreads to other parts of your body. So it goes down like that, okay? So other times you have formation of papules, and what you'll notice is, for example, you can sort of see here, is that opposed to here where the rash is very widespread and apart, you can see this is coalesced to form one really big rash. So that's another feature of measles and very rare. So I just put this in here, I don't want to say buzzword, but it's important nonetheless, is that especially in males and in the young people, a rare complication, a rare but known complication is this subacute sclerosing panencephalitis, where you can have brain damage as a result of measles. Okay?
Many years down the line.
Many years. So 5 to 10 years old. Okay, so this is another type of exanthem. So the lesion is here. So it's described as a small, so usually less than 5 millimeters. Okay, discrete, which means by itself. It's waxy and it's dome shaped, and it's a papule. Okay, it's a molluscum. Perfect.
Isn't that commonly described as yes.
Yes, so central umbilication. But the thing is that it would be possible, but it would be difficult to see that with your naked eye as well. Okay, central umbilication. Now, what's important to know about molluscum is the management. What is the management?
Or you can keep
Yeah, okay, very good. Okay, and this one as well. So much like anything, it can get infected. Nothing. I'm pretty sure it's nothing. Or yeah, okay. All right. So this one. So this one is a big giveaway. You get tonsillitis/pharyngitis before you develop these types of symptoms. What organism usually is implicated in tonsillitis/pharyngitis? Gas, which equals strep pyogenes. Okay, so strep, as we've talked about before, can cause literally everything. Okay, and it causes this as well. Okay, so sore throat is related to that. Fever, coryzal symptoms, fatigue, coryzal symptoms again. So you begin with the throat, and then you get this rash. Okay, which is described as confluent, which I'm actually not sure what confluent. I'm pretty sure it means covering everything. Okay, multiple. So there's many of these minute papules, which is described as a sandpaper rash. Okay. I'm actually 100% sure about the timeline this time because I didn't have time to research it. But you get mucocutaneous involvement. So this is called a strawberry tongue. So this is how an early version looks, and this is how a late version looks because you have desquamation. Okay, which is why it looks so dark. Okay, otitis media is not in the pictures, but you can understand what otitis media is because you start off with an ENT infection. Actually, sorry, these are just complications. So otitis media is the most common, acute GM because you have strep and rheumatic fever down the line potentially. So what is this condition? Scarlet fever. Okay, so this is scarlet fever. So the reason you get this is because gas, it gives off a toxin, and then your body reacts to the toxin. It is also, importantly, what you need to know about it is that it's a notifiable disease. Okay, it's notifiable, and they need to be on oral penicillin. So PO penicillin. Okay, and they can return to school usually within 24 to 48 hours. Okay, 24 to 48 hours of exclusion, but not much longer than that. Okay, I don't know. I'm not sure. Okay, and how would you diagnose it? Okay, now this is important because we're dealing with gas here. How would you diagnose it? So you're raising ASOT titer, okay, or your anti-DNase B, your classical things from third year. I think it's third year. Okay, so now we've gone through our EMQ block. Now we can answer the questions. Okay.
Before you go on, just the correction on the NMRV thing. NMRV is at 12 months and 18 months. The 2 for 6 months is the infant exam.
Okay, so it's not 2, 4, and 6?
No. Yeah. NMR is 12 and 18.
Okay, so 12 plus 18 for MMR. Thanks, Dongju. I could remember the 12. Okay. All right. So 4 years old, otherwise well, PTK on her lips and arms are weak. So remember, what did we say the incubation period for hand, foot, and mouth was? Very long. Okay. So what does she have? Hand, foot, and mouth. Okay. Next one. Pale looking, widespread PTK, cervical lymphadenopathy, 2 years old. It's not vague. This is not vague at all.
The only thing that gives it dependent.
Okay. So pale, what can pale be? Anemia, potentially. Widespread PTK is usually attributed to thrombocytopenia. Okay, and they have lymphadenopathy. Now, in lymphadenopathy, there's one thing. So remember I said, when we talked about ITP, remember, ITP is an exclusion, is a diagnosis of exclusion. If they have lymphadenopathy, it's never ITP. There's not many, viral infection can give you ITP, but in the setting of having anemia and thrombocytopenia and lymphadenopathy, what do they have? They have some kind of leukemia, and that is something that you really need to be able to identify. Remember last time, I can't remember last time we harped on and on about leukemias, okay? And the common symptoms, the only way to differentiate between leukemias was usually time frame and age and the epidemiology, like who it affects, because usually the symptoms are always the same. You always have anemia. You always have infections because you have changes to your white cell count and how mature and how functional those white cells actually are. And you have bleeding/bruising because you have no platelets. So it's usually it's not a pancytopenia, that's not correct, but your blood cells are not working properly. So you always have that common triad. So just keep that in mind. That's why I talked about it so much last week, because it's really important. Okay, 3 weeks ago. Okay, so 5 years old, red rash on her cheeks after having a low-grade fever for the preceding few days. What is it? Which would be? So is it that? No. Is it that? No. Is it that? No. Is it that?
Yeah.
Yes. Okay. Why do they include low-grade fever? Because this condition could also be roseola, okay, which also presents.
Get a Leo Wayne here.
No.
W-A-N, Leo.
No worries. If you're at home, Leo, when we say hello. Okay, so they've included low-grade fever here because it could have been roseola, which also presents with a malar rash. But remember, roseola has a high fever. Has a high fever. Then after a period, you develop the rash. Okay, that's why I included time frame in all of those slides that we just had. Why did I do this? Oh, great. Oh, this was, God, I spent so long on this. Okay. Okay. Tell me what you're going to see on the blood test results. AML. Remember quickly, we're already running out of time. Let's say we're doing an FBE for everyone. FBE results. Okay. Increased white cell count. Okay. So AML. So remember, AML and ALL are both going to have increased white cell count. How do you tell them apart? We talked about this, remember, 3 weeks ago. So remember, ALL is going to have increased lymphocytes, whereas AML is going to have increased white cell counts, but not specifically lymphocytes, because ALL is affecting your lymphoid progenitors, AML is affecting your myeloid progenitors. Okay, so increased white cell count. Aplastic anemia, what would you expect on FBE? Pancytopenia. Pancytopenia. Okay, beta cell?
Anemia.
Oh, you need to be more specific.
Presenting under
So I just want FBE.
Yeah, microcytic anemia.
Okay, so decrease MCV. What else?
Decreased HC.
Yes, decrease HB. Okay. What was it? Okay, we'll leave it at that. Okay, and the beta thal is important. We need to talk about it. Okay, so actually, we will get to it. Okay, DIC. What will we see? Yes, decreased platelets and decrease. Well, that's not on the FBE, true,
Yeah.
but decreased fibrinogen, folate,
Microcytic.
increase MCV, G6PD.
There'll be normal cytic.
Remember, we're just talking about FBE.
Yeah.
Okay, G6PD.
Normal cytic anemia.
No. Yes, why?
Oh.
Why did they get? So I'm gonna write. No, not really. Yes, okay, because you have increased reticulocytes. Okay, okay, we're gonna come back. So HUS.
Equal.
Okay, first, okay, let's revise what HUS is. What's that triad?
Red.
Okay, so what I'm trying to get is hemolytic anemia. Okay, hemolytic anemia. Yes, renal failure because you have it. That's why it's got uremia in their name. So uremia. So I'm just going to AKI there. And number 3. Yes. Okay,
Right.
decreased platelets. Okay. So what is it preceded by? What's the natural history?
EHEC. Oh.
That is not what. That's not the natural history. That's the organism.
Okay, fine.
Bloody
Dysentery.
diarrhea. Okay. Okay. So that's usually due to EHEC, but it can be due to other organisms because it's a Shigella-like toxin that causes the syndrome. Therefore, Shigella is also implicated. Okay. Now, hereditary spherocytosis, what are we going to see? Remember, FBE, just FBE. Are you sure? Yeah, anemia. All of these essentially will cause anemia.
Yeah, microcytic.
What's going to happen to the MCV? No. Okay, it's going to be small. Okay. So normally, so what happens is that with hereditary spherocytosis, you get an increase in MCHC, which is your mean concentration of hemoglobin. Okay, but you get a decreased MCV. The reason for that is you have a dehydration. Okay, so you essentially have a dehydration of cells. So you have increased concentration, but as a result of the dehydration of the cellular contents, you get a decreased size in the MCV. However, that is not always the case. Usually it's the MCHC, which is always high, but MCV is not always low. But typically you'd more expect it to be low rather than to be high. Okay, iron deficiency anemia, what are we going to see? Okay, that's not good enough. I need something else. Yes, RD, what happens? Yes, why? Not exactly. So IDW is a direct measure of something called ankylocytosis. Okay, I can't remember how to spell it. Ankylo, something like that. Okay, so this is a measure of how unusually sized each of the red cells are on your blood film. No, it's ankylocytosis. So IDW is a direct measure of that. In IDA, you have an increased IDW because you have a random assortment of sizes. Okay. Now, very similarly, you'd also expect that with beta thal. So beta thal also has an increased IDW. However, in 80% of people with iron deficiency anemia, they'll have an increased IDW. In 50% of patients, it'll be increased for beta thal. So you have 80 versus 50%. So it's more likely to be associated with iron deficiency anemia having an increased IDW rather than beta thal. Okay? Yes. How do you spell it? Okay, you guys can figure it out at home. Okay, so for hereditary spherocytosis. Okay, all right. So I wrote it down here. So hereditary spherocytosis, you have a decreased MCV because of membrane loss. Membrane loss is one. And number two is dehydration. Okay. Because it's a membrane defect. It's a defect of the membrane itself. That's what hereditary spherocytosis is. So because of the defect of the membrane, you have leakage of cellular contents. And because of the dehydration, that is why you have an increase in the hemoglobin content, which is why MCHC is high. Okay, makes sense? So IDW is a measure of how unusually sized each of the red blood cells are. So in iron deficiency anemia, 80% of those patients have an increased IDW. only 50% have an increase in beta thal.
So why did you?
I'm not 100% sure.
It's just skewing out any cell.
Yeah, I thought it was like a production.
Some get iron, some don't get
There
iron.
you go. Okay, perfect. Okay, what is SDS?
Shachman-Diamond syndrome.
Shachman.
Whatever.
Okay.
You're expecting me to
Okay, quickly tell me about it. What is it?
exocrine pancreatic insufficiency, short stature, and pancytopenia.
Okay. First of all, okay, it's rare. It's autosomal recessive. You're absolutely correct. It's exocrine. It affects the exocrine pancreas, and the only reason you need to know about it is because other than CF, so CF is the number one cause, so number one of exocrine pancreas insufficiency. Number 2 cause is therefore SDS. Okay, that's why you need to know about it. Now, how do we measure somebody to have exocrine pancreas dysfunction? Fecal elastase. So that therefore is also going to be elevated in Shachman-Diamond syndrome. Now, what are you going to see in Shachman-Diamond syndrome? Typically, what you see is a neutropenia. Okay, and you see decreased platelets as well, and you see decreased HB. So that's the classical findings. Now, the reason you have exocrine pancreas dysfunction is because you do not have acinar cells. Okay, whereas in CF is just a blockage. All right. Now, Shachman-Diamond is a bone marrow failure syndrome. Now, if you have continuous bone marrow failure, this eventually, in some patients, can result in AML. That's just another thing to remember. Now, B6, what is B6? Pyridoxine. Okay, so pyridoxine deficiency usually causes dermatological symptoms. Okay, it's not pellagra, but it causes. That's nice. Is it niacin? Yeah, it's niacin. So vitamin B6 causes more like sebderm type of picture. Okay, the last one, vitamin B12, you know, I hope. Yeah.
Yes.
Vitamin B12 causes.
So that could combine.
Yeah, no, that's good. Subacute combined degeneration of the spinal cord, you need to know that. Peripheral neuropathy, and also causes a macrocytic anemia,
Yes.
and it's also associated with pernicious anemia. Okay, just important things to remember. After all this, we've only got a question now. Okay,
This always happens. Why are you surprised?
6. Yeah, this is true. Mildly anemic. Okay, microcytosis, hyperchromia, So first of all, what are differentials? And okay, we just talked about beta thal, so similar. Okay, undergoing to blah blah blah. HbA2. Yes, so that's diagnostic. Okay, beta thal. So if we have a look here, this is what. So when you're a neonate, when you're in your mom, what's that called? A fetus. In utero. So when you're in utero, usually you have fetal hemoglobin. Okay. Now within 6 months, so within the first 6 months of life, you have conversion to adult hemoglobin. That is why beta thal minor presents after 6 months. Okay, because that's when you have the conversion, and the conversion doesn't work properly. Now, because they can't make HbA properly, they decide to make HbA2 instead, and that's diagnostic of beta thal minor. Now, in beta thal major, it doesn't work that way. You have less A2, and you have increase in the HbF. So that would be indicative of beta thal major. And the biggest difference between beta thal major and minor is that major presents at birth with more symptoms, abdominal pain, anemia, pallor, all those types of symptoms. I'm not 100%, I still couldn't figure out why it presents at birth, but beta thal minor presents after 6 months usually. Okay, does anybody know what this is? Yeah, so this is called chipmunk facies, and this is due to extramedullary hematopoiesis. Okay, so 14-month-old boy, so that means he's just over 1 year old, 1 year. Okay, he has pallor, poor feeding, HB electrophoresis is normal. Okay, so we'll go through this. That's low, yeah? That's normal. That's normal. And that is low. What do you think he has? Iron deficiency. And how do we rule out beta thal?
Because his hemoglobin.
Because of that. Very good. Okay. So his electrophoresis was normal. So he has IDA. Okay. So a 3-year-old boy, mildly jaundiced. Okay, HB, that's low. That's normal. So we can rule out things like leukemia, etc. That's normal. So we can rule out DIC. MCV is high. Reticulocytes are high. Okay. So reticulocytes are high indicates what? Hemolytic. Okay. So hemolytic. Okay. So from this list, what is hemolytic? Not that, not that, not that. Is that hemolytic? Not really. Okay, folate. Is that hemolytic?
Yeah.
Yes. Is that hemolytic? Yes. Is that hemolytic?
Yeah.
Yes. Iron deficiency.
Nah.
No. Is that hemolytic?
Nah.
We won't talk about that. All those. Okay. So there's three things that it could be. How are we going to differentiate between them?
Well, you can cross out the HUS
Yes. Why can we cross that out?
because he doesn't have the typical history. He doesn't present typical.
But the history is so short anyway that it'd be hard to rule anything out.
Yeah, but it's a one as exam.
Oops. Okay. Well, yeah. Reason. Okay. So
Well, where did the jaundice come
hemolysis.
from?
Okay. Now, how are we going to rule out hereditary spherocytosis versus G6PD? Yes, okay. So due to the reticulocytosis that is common in G6PD, reticulocytosis, that causes you to have an increased MCV. However, I'm still not 100% convinced that I've hit the right answer with G6PD because exactly,
Yeah.
because you can still get reticulocytosis there. The only way that I've differentiated is because of the MCV, which is very rarely macrocytic in hereditary spherocytosis. And given, if with the history gave us some sort of genetic background, or if they gave us some environment, if they gave us any indication that this patient has had some oxidative stress that will cause G6PD to deteriorate, then definitely. But in this situation, it's still hard to differentiate between G6PD and HS, but the better answer, in my opinion, is still G6PD. Okay? All right. Yes, just because of time, we don't go for anything else. Okay, 12 years old, HB is low, white blood cells are okay, platelets are okay, MCV is high. She has Crohn's disease, ileocecal. What does she have? B12.
Because that's where it's
Okay, so duodenum,
iron.
jejunum, ileum. So Dongju has a fantastic mnemonic for this.
I found pictures.
Yes. So iron, folate.
Oh, it's not mine.
That'll do. B12. Okay. So that's why. All right. Now we're on to our next. I promise after this, I think there's only like one major set that we'll go through.
That's totally right.
Okay, 9 years old, 6-month history of headaches. Okay, this is very simple. What is this? Straightforward. Migraine.
Yeah.
Okay. Now it's occurring once a month. Now you might hit me for this. I know she's only 9 years old. There's always the potential it could be menstrual related. Who knows? Okay, just putting that out there.
But it only started at 6 months.
Okay, so I've put this in here because this is RCH guidelines on how you manage migraines. And there's a few reasons I put this in. Okay, first one, environmental, so dark room, less stimulus, etc., etc. Paracetamol is always you're going to do. Okay, now there's a big difference here. Greater than 12 years or less than 12 years. So what is the difference? One, you don't give them aspirin here, okay? You don't give them sumatriptan, and you give them ibuprofen instead, okay? Chlorpromazine, the other name for that is Ligactil, okay? Now, if any of you guys have done ED at all,
Pediatric.
yeah. So I feel like a lot of you probably would have heard of clinicians that are using Ligactil or chlorpromazine. It's very common. Okay.
Yeah.
Apart from that, you probably won't see people use sumatriptan, but you'll definitely see them using paracetamol and aspirin. Okay. Now, why isn't aspirin used in this age group? Yes, Rey syndrome. Okay. What is Rey syndrome? Sorry, let me get a different color. Okay, so this is exactly correct. So rapidly progressive and KEF, if you fill in the rest. Okay, now the cause is unknown. They still don't know why it happens. Okay, so what kind of symptoms do you get? You get vomiting. Okay, vomiting. You get personality change. Okay, you get confusion. You get loss of consciousness. Okay, now interestingly, in the UK, on a consumer level, you're actually not allowed to sell aspirin to people under 16 years old. It's banned. In particular situations where you have supervision by a doctor, etc., you can use it. But I thought that was interesting nonetheless. That should help you, at least in some way, to remember it more. Okay, next one. Okay, 3 years old, 3-month history of headache, wakes him at night, vomited on awakening most mornings. What is this? Very clear. Because he has
Mornings.
Ingus ICP, so he has a brain tumor. Okay. Remember one of our other presentations, we went in detail about pediatric brain tumors. I recommend you to go have a look. Can't remember which one it was. Okay. 16 years old girl. Okay. Band like, so this is tension. Okay. All right. Okay. So our next one, our next set. Okay. Okay. Now, I'm less interested in the actual questions rather than these question stems, the EMQ sets. Okay. What's arthrogryposis? Anybody know?
Is it the same as Auschwitz but in the arteries?
No. Okay. So arthrogryposis is a congenital joint contracture. Okay. No. Oh, okay. So congenital joint contracture that affects more than two parts of your body. Okay. More than two. Okay. You know what I mean. Okay. So why do we get it? So it's an abnormal fibrosis of musculature. Which, if you have fibrosis, that equals shortening, okay? Which is why you get the contraction defects, okay? Now, there's so much, I don't want to talk about all of it, okay? But what you need to know, 70–80% of it is usually associated with some kind of neurological abnormality. So neurological abnormality, anything. So it's associated with any kind of neurological abnormality, okay? And 84% of people have all limbs involved, okay? All limbs involved. So you should be able to very clearly identify this if it came up on the question because it's quite unique. All right, that's the first one. You guys got that? Okay. Compartment syndrome. What's compartment syndrome? Okay. There's a clinical syndrome. Okay. Yes, usually secondary to what? Trauma, surgery, having a cast, etc. Okay. Symptoms. What kind of symptoms do we get? This is your classical symptoms? Yes, okay. So Paris. Let's go common first. Okay, so severe pain, okay, is number one. Severe pain, decrease in pulse. Okay, that's also a late sign, okay. Decreased range of motion. Okay, we have paresthesia. Pale. Okay, so yeah, all of these things. Now, the importance of compartment syndrome is being able to recognize it because you have less than 6 hours to manage it. Otherwise, you're going to get limb necrosis. Now, compartment syndrome is further broken down into two types, acute and chronic. Okay, so acute and chronic. So we'll talk about acute first. Now, important things to know about acute compartment syndrome. So less than 10, well, I shouldn't say less than 10% because that doesn't make sense. So, all right, up to, okay? So up to 9% of all acute cases of compartment syndrome is usually due to a tibial fracture, okay? Tibial fracture. Most common complication is rhabdo, okay? And that happens in about 25% of people, okay? Now, another common complication, if the compartment syndrome is not treated, is something called Volkmann's. Have you guys heard of this? Volkmann's contracture. I mean, the reason is the same, okay? So Volkmann's contracture, if I was to draw it terribly, okay. So that's how, like, the fingers would look like, okay? And then the thumb would sort of be there. Sort of makes sense, right? Okay, so that's how Volkmann's contracture looks like. So this is a permanent flexion contracture. So permanent flexion, so look, the hand is flexed. Yeah, flexion contracture of hand and wrist.
That's when you have it on the
Yes. Okay. So because of that, you have a decreased range of motion. So usually passive extension. So when you do exam, passive extension will be limited. Okay. And all of this is due to, so that it's all secondary to ischemia. Okay. So because the brachial artery ischemia is why you get it. And this causes necrosis of forearm flexors. Okay. So you have, so these muscles, the forearm flexors, okay, forearm flexors, they become necrotic because you're blocking off the brachial artery, which is why you get the shortening of you get the fibrosis of the muscle fibers and you get the contracture happening, okay? Because once these flexion fibers don't work anymore, the extension fibers take over, which is why your hand is in that position. Sorry, I drew it on the wrong side. Yeah. Okay. All right. Erase all income slides. So we talked about acute. Now let's talk about chronic. Okay, so chronic is usually in people who, so this is just repetitive muscle use. Okay, so usually brought on by exercise, okay, and the most common symptom is foot drop. Okay, is there anything else I needed to talk about? Okay, and the reason it's important is this is why anybody in ED that you put a cast on for any kind of fracture, so after you've reduced a fracture and you've put an immobilizing cast on them, you need to get somebody to review them, whether it be the GP or them coming back to the ED within 24 hours to make sure that it's not swelling enough to cause them compartment syndrome. That's the clinical key thing that you need to remember. Okay, so DDH. Okay, the DDH. So what is this? Yes, okay.
A rich boy with family history.
So it's usually just an abnormal head to acetabulum relationship, I'll call it. Okay. So the two tests that we do is Ortolani, right? Ortolani or Barlow. Okay. So Ortolani, the way you remember is out. Okay. And this one you remember as bed. Okay. So Ortolani out, this is trying to test if the hip can be dislocated and be reduced back into the acetabulum. So what you do, so when the baby is in that position, you move the legs out and then you try and push them back into the socket. So I'm not sure how to draw that, but so moving it out, trying to push it back into the socket. So then moving it back into the socket causes the classical clicking sound. So that's the click. Whereas Barlow is trying to see if the hip can be pushed out of the cup. So you get the legs up and then you push them down onto the bed. And you're trying to see if that slips out of the acetabular cup. Now, if the acetabulum is not normal, if it's a bit shallow because it hasn't developed properly, then it's very easy for the femoral head to slip out. So that's why we do those tests. Okay, so normally the management would be pavlicanus, for example, to try and immobilize those joints. If that doesn't work, you can do a hip speaker, which is just plaster around the hip joint, which is a closed reduction essentially. And if that doesn't work, then you can do an open reduction, which is when you actually need to get a surgeon involved. Now, the only other thing that is important is ultrasound. Okay, so ultrasound, this is what you need to say in your OSCEs. So ultrasound at 6 weeks. Okay, for the hips. So hip ultrasound. You're looking at the hips to see if there's DDH there. Okay. All right. Sever's disease. What's Sever's disease? So Sever's disease is exactly the same as Osgood. Okay. So remember, this is tibial apophysitis. So this is a soccer player who always uses it and they have pain over their tibial tuberosity. Sever's disease is a calcaneal, okay? So calcaneal apophysitis, okay? So similar type of symptoms, just in a different place in your body, okay? Does that make sense? Well, I don't see how it wouldn't make sense. I don't know why I asked. Okay, all right. So we're just going to very quickly go through these. So what do you think this is? So this is Sufi because it's a painful limp 3 days earlier. Okay. Actually, the only thing that is important is how is this, okay? Is this particular thing, okay? So somebody with Sufi, they cannot internally rotate plus abduct plus flex, okay? So with Sufi, what happens is slip out from, okay. So what happens is the metaphysis, okay? So the metaphysis, so if I was to draw a bone, okay, to draw a bone on both sides. So this is the metaphysis, okay? And this is the part that is slipping off. So then what happens is the metaphysis, so this long part of the bone, okay, it starts to rotate, okay? And it becomes anteriorly. So it comes anteriorly and it becomes externally rotated, okay? So instead of being in the normal position in your body, imagine it came forward, okay, and it rotated outwards. Because abduction of the hip is done completely by glute medius, okay? And your glute medius attaches to your femur. So if that metaphysis, the long part of your bone, is coming forward and it's rotating out, it's going to be lax. So when those gluteal muscles are trying to abduct your hip, it doesn't have any tension that's pushing against it. So you're not able to externally rotate or abduct or do any of these movements. You can't internally rotate and you can't flex. So your leg is going to be in an externally rotated position. So that's why you see that specific finding in Sufi. Well, it's not specific, but you see it very commonly in Sufi. Okay, so very quickly to go through this. So 7-year-old boy, he has a worsening limp. that's important because for Perthes disease is an indolent progression, right? It goes from painless to painful, okay? Because this is idiopathic AVN, okay? AVN of the femoral head, which is why it goes from painless to painful, which is why it's a worsening limp over 2 months. All right, a flattened femoral head because it's dead, so the answer here is Perthes disease. All right, going on to the next one. So a 3-year-old boy, he has high fever, refusal to walk, 38.5. What does he have? Septic arthritis. So I know I keep grilling this into you guys. I hope I have a picture there. Oh, I don't. Okay, anyway, look at the RCH guidelines. It has a box there specifically for how to identify a baby has or someone has sepsis. Definitely high fever, not wanting to walk is septic arthritis until proven otherwise. Okay, so this is just that one, yeah, transient sinusitis. Okay, all right. So 5-month-old child, mildly febrile, cough, shortness of breath, respiratory distress. Brother recently had an OT, so he has a sick contact, widespread wheezes and crackles ahead on auscultation. What is this? Brock, but how do you differentiate that from something else? Versus pneumonia, versus croup, etc. Yes, widespread, age. Okay, that's very important. So what is the organism here? RSV. Okay, so why does it affect this age group? So usually less than 12 months old. Does anybody know? Okay, because they have immature lungs. Okay, so immature lungs, they do not have smooth muscle, which is why we can't diagnose a neonate with asthma. Okay, because for asthma you need smooth muscle and you need smooth muscle receptors. That's why we call it viral-induced wheeze. So because they don't have smooth muscle, they're very susceptible to get congestion of the lungs, and that's why they get bronchiolitis. Okay, now, so bronchiolitis is a pretty easy diagnosis, but what's more difficult is if you're in an OSCE, what are you going to say for management? Okay, now another thing is that, so on the RCH page, their triad of bronch is cough, if you have tachypnea, if you have retractions, okay, and then if you have for widespread wheeze and crackles, word for word. Okay, now what you do need to be able to do in OSCE is able to communicate whether they have mild, moderate, or severe disease, because that changes your management. So if a baby comes into your ED on day 1 of bronchiolitis, are you going to keep them? Are you going to discharge them home, or are you going to refer to peds, and why?
Yeah.
Yes, okay, that's very important. So the natural history of bronchiolitis is that it gets worse, okay? Usually getting worse on day 3 to 5, and then getting better within a week. So that's why if they're presenting early, you cannot discharge them home, you need to refer to peds. If they have any kind of oxygen requirements, if they have an O2 sat less than 92%, if they have any kind of severe increased work of breathing, you need to refer to peds. So all I'm trying to tell you to do is you need to have memorized or do whatever you need to do to be in an OSCE able to very quickly and accurately diagnose whether it's a mild, moderate, or severe increased work of breathing. Okay? Okay, so we're not even close to the end, but we'll keep going. Okay, so unwell, 3-year-old boy, cough, fever, malaise of 2 days duration, respiratory distress, unilateral cramps, and irritability. What do you think he has? Lobar pneumonia, okay? So it really is this thing, the unilateral crepitations is not, it's always pathological if it's unilateral, okay? Now, so again, from RCH, PNA is a clinical diagnosis, okay? So clinical diagnosis, and it's diagnosed when, 1, there is signs of a lower respiratory tract infection. So what here is a sign of a lower respiratory tract infection? The fact that he has unilateral crepitations, you can only hear that in the lungs, right? So that is not the upper respiratory tract. It's not your trachea, it's not your bronchi. So he has lower respiratory tract signs. And remember, this is from RCH. So 1. Number 2 is you need to rule out. So rule out other wheezing syndromes, okay? So I know it hasn't given us in this STEM, okay? But the fact that it hasn't mentioned that the patient has a wheeze should be enough in this situation, okay? All right. And then there's no number 3, but what you need to know is that you give them amoxicillin for everyone, okay? And amoxicillin, and if they have an allergy, so amoxi, okay? And if they have an allergy, so if you can't use that, then you give azithromycin. That's the only really important thing to remember. You can remember the other antibiotics yourself. Okay, So 2-year-old boy, abrupt onset, okay, abrupt of cough and dyspnea, moderate respiratory distress without localizing signs. So he doesn't have cramps, he doesn't have any of those kinds of things. Okay, mediastinal shift to the left with an expanded right lung. Inhale foreign body. Okay, so remember it always goes down the right main bronchus most of the time because it's more straight, more straight and shorter or something, which is why it goes down the right side. So you can see a foreign body there. That's not the actual picture, but I got a picture. Okay, so 4-month-old infant born at 24 weeks, inspiratory and expiratory stridor. No.
Oh, sorry. I didn't
Yes. Okay. It's important. See, a lot of people would have easily been caught out by that on the exam. It's important to note. Okay. So this is a picture of subglottic stenosis. Now, there's another important thing in this stem. There's something very important in this stem that tells you subglottic rather than laryngeal malacia. Yes. Why is that important? Yes, intubated. Okay. And that is not a buzzword because that's actually the most common reason people get subglottic stenosis. Is usually secondary to trauma, and that trauma is usually intubation. Okay, so what you can see here is you can see stenosis. You can see narrowing of the trachea in that location. So if we were to look at pictures, the top one is laryngeal malacia. So this is a supraglottic, okay, supraglottic stenosis. So when they breathe in, okay, when they breathe in, it's very hard for the air to get past there, right? But when they breathe out, they're able to stent that airway, so you don't get the sound on expiration. Whereas in subglottic stenosis, it's always small, which is why you get the sound both in inspiration and in expiration.
So what's the picture?
Which one?
The picture.
So these are the vocal cords, right?
Yeah, the picture on the top.
Yeah.
What's the what?
This one? This one. So this is the laryngeal malacia. So this is a supraglottic stenosis. So what this is actually described is an omega-shaped glottis. I'm pretty sure. Okay, but that's how it looks like. So this is a classical finding that you see in the laryngeal malacia. Okay. Another important thing to remember about subglottic stenosis usually self-resolves by 2 years old. Okay. And another thing is that with laryngeal malacia, remember we just said shouldn't be there on expiration, and it also gets quieter when they're resting and when they're asleep and when they're supine. Yes. Okay. So I was gonna have stuff there, but I didn't. Okay. So 7 years old, so he's old, 2 similar episodes before, suddenly unresponsive, stops breathing, jerking movements. What do you think he has? He's 7 years old. Does a 7-year-old have breath holding spasms? Yes, no. I'm gonna have lots of notes here. I really wanted to go through it, but we definitely do not have time today. I highly suggest you to go through it. But this is just your normal generalized seizure, okay? So, yeah, I'm not going to go through that. Okay, 7-month-old, okay? 1 week history of drawing up of his legs, flinging out his arms.
Salam. Infantile spasms.
Okay, so salam attacks. So this is infantile spasms. Another name for that is West syndrome, okay? So all of the information is here. I highly suggest you go through this because you very easily could get OSCE questions on this, okay? So I guess the only thing to point out is this Vigabatrin. So that's what you use. And you need to know these, look at a video because it is exactly how it sounds. They literally put their arms out like this. Okay. So 5 years old. She has small pause in activity. She has absence. It's on here somewhere, I'm sure. Yes. Okay. So absence is also here. So this is an important feature. Automatisms also occur in partial epilepsy, but it's also present in absence seizures. Okay. Okay. So now, just with the other things on the list, there's some more notes. So Rolandic is really hard to actually diagnose because there's not many, other than the EEG findings, there's not many characteristic features. But I think this is from a past exam. Was that? Mostly at night. Okay, so partial focal seizures, that could range many different things depending on where the actual focality is. So just keep that in mind. Dravet syndrome is important because this is multiple seizure types, okay? And juvenile myoclonic epilepsy, okay? So this is the thing. He has a single involuntary movement. which is why the answer to that first question was not this. Okay, what do you think this is? So 3 years old, she's had a brief tonic seizure for 3 minutes in the midst of an episode of fever, febrile convulsions. Okay, now very quickly, give me the dot points of what you need to know for febrile convulsions.
With high fever.
Okay, what else? Okay, what else?
Shouldn't, if it's simple, shouldn't happen more than once in per febrile episode.
Okay, so the better way to talk about this is what do we define as complex? Okay, so there's 4 things that you need to know for complex. So let's get a color. So one, what did we say? More than 15 minutes? What's another thing? Yeah, so recurrence. What else? No? Oh, okay, sure. Focal features. Okay, number 4. So if they're post-ictal for more than 1 hour. Post-ictal, more than 1 hour. So this instantly makes a febrile seizure go from a simple seizure to a complex seizure, and the management changes, okay? Now, there's other few febrile seizure types that you need to know. So febrile status, so febrile status is defined as more than 30 minutes. However, usually you should call it, you advise the parent to call the ambulance if it's lasting more than 5 minutes, okay? And the other one is you can have an afebrile seizure. Have you guys heard of this?
Yes.
Okay, so that is when you don't actually have a fever, but the seizure is occurring within an infectious period. So a good example is gastroenteritis, where you don't always have a fever, but you still have a very clear infection. They can also get seizures during that period. How do we manage it?
Still manage the same as febrile seizures.
Oh, but like also febrile seizures as a general, how do we manage?
Go home.
Yes, so reassure.
Education.
Okay, what does the education give them?
Give them a patient equal pen.
Okay. Be more specific. What do we tell the parent to do if it happens again?
Them on the side, like, don't use your own fingers.
Okay, so protect them. So protect. What do we tell them about epilepsy risk? Okay, so same as population is 1%, unless they have risk factors. So what are risk factors? Family history. Okay, family history. What else are the risk factors? Yes, yeah. So neurodevelopmental disorders. So that increases the risk depending on how many you have to 10 to 20%. So if you have 1 risk factor is 10. If you have 2, I think it's like 20 or something. No, sorry. What am I saying? It's 2 to 10%. 2 to 10%. Okay. All right. Forceful bile stain vomiting shows gas only in the stomach and a small amount in the duodenum. Yes. Okay, so there's a whole presentation on this, so I'm not going to go through this in too much detail. Okay, so term baby with vomiting, poor feeding, temperature instability. What does he have just from that? Sepsis until proven otherwise, right?
Yeah.
Okay. Now, why did they include this here? Why cell count immature? So what they're trying not to be too obvious and give you an actual Y cell count. What they're trying to say is that you have a left shift, okay? And a left shift happens when you have an infection. So it means that they have a neutropenia, okay? So, this is where I wanted. So this is straight from RCH. So anybody who has this has sepsis. Okay. So baby presents at 3 weeks, vomiting from birth. Vomiting is effortless. So what does he have? Effortless vomiting, mostly after feeding. So gore. So when does gore become gored? Yeah, that's one thing.
Symptomatic.
So if it's frequent, okay, so after every feed, so that's more than 5 times a day, okay. If there's sequelae, okay, so if they have poor sleep, if they have other clinically significant stuff, then it becomes gored. Okay, that's important. Why was it important? There's an OSCE, I think it was like an OSCE question or something like that. Okay, so a 13-year-old boy, he has concern about his growth. He has always been among the shortest in his class, but recently the gap has widened between him and his peers. His father tells you that he was also short, but he is now of average height. Constitutional delay, okay? So that's very true. So if you have a look at this graph, what you notice is that this line is exactly as he was describing. Actually, maybe I should use another color. So in the question, so he was always shorter than his peers, and suddenly that gap increased, probably because everybody else was going through puberty and he was having a delay, okay? But eventually he gets back to the same level. So that is the definition of constitutional delay, is that you have a short stature, but eventually you reach a normal adult size. So that is why they included that in the STEM. Okay, so 4-year-old girl, she is short-sighted relative to her family. She was born at 36 weeks with birth weight of 1,500. What does she have? IUG. So what is normal birth weight?
Above 2.5 kilos.
Yes, so usually be above 2.5. So in this case, we describe her as small for gestational age. Okay, small for gestational age can be either placental mediated or non-placental mediated. That is very significant. I think I have a picture, don't I? Yeah. Okay, because if it's not placental mediated, it means that something else other than not being able to get enough nutrients to you was causing the problem. So for example, if you actually had a developmental disorder, if you had a chromosomal disorder, or if you had a fetal infection, so something that is not because of how much I'm feeding you is causing you to be small. And the reason for that is important because that will cause neurodevelopmental issues. If it is placental mediated, then you don't have neurodevelopmental issues. So why do we get IUGR? So many things. So maternal conditions, if we have preeclampsia, if there's something autoimmune, if we have thrombophilia, renal disease, etc. Diabetes especially, diabetes is very important. Anemia as well, substance abuse. Okay. 8-year-old girl, short stature. She was growing up well. Her performance score has declined this year. What do you think she has? Yeah, so this is very classical of how hypothyroidism can present. Now, cretinism also presents similarly. Okay, so cretinism has mental retardation. I'm not sure actually. Are you? Well, I think they're called congenital hypothyroidism these days. So congenital hyperthyroidism. Okay, obesity and short stature. So that is your triad for congenital hypothyroidism. But I wasn't actually able to find what the natural history is. So what I mean by that is, how do they actually progress? Yeah, okay. So like the reason I was querying that, because I wasn't sure if by 8 years old, would they still have no symptoms and then suddenly present? I find it unlikely. But otherwise, she probably has some sort of acquired hypothyroidism, which is causing her to present like this. Okay, so 11-year-old girl, she has 3 kilograms of weight loss over the last 3 months, abdominal pain and diarrhea. This is classic, okay? Penny lump rash on her shins, she has. Are you guys sure? Celiac, okay? So it's more likely celiac, okay? Because, yeah, okay? So because of the wasting, I'm still not sure what the pathophysiology is behind that. And, well, okay, she has lots of weight, okay? She has wasting, regardless, she has wasting, okay? Wasting, okay? And she has dermatitis herpetiformis, okay? The reason for that is because it's a painful lumpy rash. So if you have a look here, this is how dermatitis herpetiformis presents as, and that's what you need to know. So the answer to this is likely celiacs. Now,
does it look like 11-year-olds?
Performance is generally described as itchy rather than painful. Painful is more like
okay, feel free to debate it. Okay. Otherwise, what we need to know for celiacs is what's the chromosome we use to diagnose it?
Chromosome.
So I mean genetic marker. HLA DQ2/8. Okay. Important thing is, why does the GP refer somebody? So the GP. So somebody comes into the GP clinic. They say, for a really long time, I've had this abdominal pain and diarrhea, especially when they eat these foods. So GP says, okay, you have celiacs. They do the antibodies and they all come back positive. Then they refer the patient to the ped surg clinic. Why do they do that? To ped surg. So the question I'm asking is that in the clinical setting, the GP will do all of these tests, and then he'll refer the patient to the ped surg clinic. What's the reason he makes that referral? Yes. Yes, okay. So the GP is not someone who can do that. So they refer them to the ped surg clinic so they can they can book them in to have a duodenal biopsy. Okay. So duodenal biopsy, because that's how you diagnose it. So you get them to eat these gluten, lots of things that contain gluten for a few weeks. Then you take the biopsy and you look under a microscope to see if it is it's celiacs or not. Okay. So you do that. Then after 12 months, you repeat it again. Okay. Why do you repeat it? To see if the no gluten diet has actually worked or not, and to also see that it's not another problem, because things like gastric cancer especially can present similarly. So you need to check that it's not gastric cancer and it is celiacs, definitely. Okay, we're sort of nearly done.
Are you only doing 3?
Yeah. Okay. Now we'll do the whole. Do you want to do the whole paper?
No.
We're gonna skip this. So bright red cheek, she has roseola because she has high fever. I'm pretty sure. No, sorry, she's low grade fever. What does she have?
Lipstick.
Yeah, A. Okay. So high fever, roseola. Okay. He has a tonsillar exudate, lymphadenopathy, hepatosplenomegaly. He has glandular fever, so he has
Yeah.
EBV. Okay, EBV.
Uh,
Okay. And so she has cough, conjunctivitis, coryza, buccal mucosal lesions, which are called Koplik.
yeah. Wait.
Sorry. No. Look, she has high fever, cough, and conjunctivitis. She has wide buccal mucosal lesions, which are called Koplik spots. Yes. Okay.
I didn't say.
Or do you say? I thought someone said Kawasaki. Okay. I said somebody said Kawasaki, which is also very reasonable because she has a long day. She has a long period of fever, so that is a very reasonable diagnosis to make. So everyone who laughed should take it back and should give a pat on the back to whoever said Kawasaki.
Did you say Kawasaki?
I didn't say Kawasaki's. Okay, but that's why I put the timeline in because she started. So remember, it starts on the face and then it spreads to the trunks and the limbs. So this is measles. Okay, so 7-week-old. Okay, they'll join us on day 3. Recurred around the 4th week. Oh, this is when they gave up with preparing. Okay, bilirubin is raised. Okay, what do you think they have? So they have an obstructive jaundice.
Yeah.
So what do you think they have? What's an obstructive? So is that obstructive? No, that's unconjugated. That's unlikely in the child.
Yeah.
That's going to cause unconjugated again due to hemolysis. Again, same thing. I can't even remember what glycogen storage disease is. Same as CMV. Rhesus incompatible, same as ABO, sickle cell. So what's left is an obstructive cause of jaundice. Okay.
Why would it present 7 weeks?
Yeah.
I can't remember. I don't know.
A bit late.
Okay. So 32 weeks, notably jaundice and unwell on day 2 of life. Temperature instability always makes you think, do they have sepsis or not? Always keep that in mind. Okay. Feeding poorly, lethargic. Blood group is ORH negative and negative. Unconjugated hyperbilirubinemia. What do you think they have? Yes, perfect. Okay, so full term 3.9 kilograms. Is that big?
Nah,
Yes.
it's like whatever.
I think
Whatever.
It is acceptable.
Yeah, it's like whatever.
so. Join us on the first day of life.
Big.
So that's pathological.
Fuck.
Okay, so pathological jaundice. It was high. It was unconjugated. Okay, begins blah blah blah. So mother was O and the baby was A. What does they have? ABO. Okay, so mommy is A negative and B negative, whereas the baby is A positive and B negative, right? So that's incompatible. Okay, so 26. Oh crap! This is why I should have prepared because I didn't look at ETG. Okay, 26-month-old, fever on 39.4, painful left ear, atopic eczema, blah blah blah. Coryzal symptoms without fever for 4 days. Left tympanic is dull, opaque, and bulging, with a spreading onto the. Ah, that's really important. What is that? What could that be?
Mastitis?
Yeah. Or mastoiditis. Okay.
Yeah. That's something.
So mastoiditis is a emergency complication of otitis media. And what antibiotic do you give them? Now I'm relying on you guys here because I actually don't know the answer. Is that amoxicillin? You sure?
I have the GP. but
Unsure. So all right, look on ETG because I didn't. Okay, amoxicillin. All right. 13 years old, requires prophylaxis following emergency splenectomy. What do they need? Yes. Again, look on ETG because I didn't. Okay, 9-year-old, holiday in Bali, now has abdominal pain and diarrhea, giardiasis, metro. Okay, I feel like that probably doesn't need to look on ETG. Okay, 9-year-old, she's noted to be very small, below the third centile, noted to have a webbed neck. What does she have? Widely spaced. Nipples, tennis, I feel like it's a mnemonic, but doesn't matter. Okay, 4 years old, maternal concerns about height and weight, neonatal jaundice. He had an echocardiogram which investigated myocardial pulmonary stenosis. What do you guys think he has? Say again? Why do you guys think that? So jaundice? And? Does he have a third?
Does he have a British Y kind of?
Anyway, could be.
Whatever.
Yeah, okay, we'll get allergies. Okay, now he came from Pakistan, diarrhea with significant weight loss, distended abdomen, buttock wasting.
Oh, yeah, there you go. But
celiacs. Okay. Okay. So what's the rule? So if they, so what do we use for bolus?
It's like,
Okay.
and then
So
half
10 to
and
20,
half
that's
again.
absolutely correct per kilogram. Because there isn't a 300 here, there's only a 150. The answer is 150. Okay. So this child needs maintenance fluids. And the only way that you know this answer is if you actually looked at. Oh, actually, let's. Will that actually work? I actually didn't try that. Okay. So 4, 2, 1. How should we calculate it? So 4 times 10 plus 2 times 5. Okay, equals 40. 5 equals 10.
So this is the step.
Yeah, this is not the 24 hours.
No, isn't fluid maintenance calculation different?
Yeah, but same ratio.
The answer here is 750. Okay. Now the reason, so other than rules, you need to look at a table on RCH. So RCH is a table which I didn't copy in here. So if you just type in like intravenous fluid therapy RCH, it gives you a table on what milliliters per kilogram you need to use per age group. And in this age group, I think it was 50. So 50. Oh, sorry, for the weight, might have been the weight. So
It's always fine.
let's just have a look.
It doesn't look right.
Is it?
This is 24 hours, should be 125 and something.
Yes, right.
Doesn't the maintenance fluid use different formulas?
CH,
Yeah,
The
but
step-
I,
yeah,
V,
yeah,
step.
Yeah, stepos is like 421.
that's
This is
maintenance.
maintenance.
Yeah, this is the maintenance, which is gonna be different.
41 is per hour. 150. 150 is like 4.
Yeah, then you're gonna
They're both the same thing. They're just one's taking by hours, one's taking by hours.
This, isn't this for 24 hours?
Rupert says use the 150, 20,
It's just
to
easier.
calculate.
RCH, IV fluids. Can you see that? I know you can't see that.
Yeah, I think that's
Different if they have one section.
Okay. So what I'm trying to do,
Alright, let's have a look.
where's my mouse?
Like on the left side of the screen, and now you just jump back. There it is.
Okay.
Okay.
So maintenance. So if you look at the weight, 50. So 50 mils per hour. Okay. So 50 times 15 is 750.
Okay.
This
It's
is-
for hours.
No, this is
That's
no.
per hour though.
He was just for fasting.
Isn't it for the first 10 kilograms?
This is direct from RCH.
No, he's fasting for
Yeah,
24 hours.
Yeah, so 50 by 24 should be close to 1.2 liters. This is for the 24 hours.
Right. What's 50 times 15?
Why are you telling?
No, you wouldn't give 2/3.
But why are you
because-
timing 15? It's milliliter per hour.
Oh, my bad. So 50 times 24 is how much?
1200.
1200. Right. We finally got there. That one. Okay. Whoops. Shit, how do I get back there? Okay. Well,
can't get it. It's not this YESPA mixtape.
Oh, yeah, that's true.
What?
You should use the 150, 25. It's for 24 hours.
which one?
The 150 and 25.
I've never heard of that.
I should be updating.
Okay, tell
It's
it.
for 24 hours maintenance.
Okay, how do you do
That's
it?
how we pick
How do you do it?
So it's the same rule. So for the first 10 kilograms, you times it by 100. So 100 mil per kilogram for the first 10 kilogram.
Equals 1000.
Yeah, and then for the second 10 kilogram, you do 50.
50.
So
You can
50.
halve it every time.
So 5
Yeah,
equals 250.
yeah. Then
There you go.
and then the last
Okay.
one is just 25.
So 24-hour rule
Yeah.
is 150, 50, right?
No.
No, 100.
150, 25.
150.
It's the
Halve it
same
every time.
ratio.
150, 25.
No, 100, then 50, then 25.
Ah, right.
It's
Okay, we got there.
still
Not 150, 100.
As you guys can see, I was very quick by the end of this presentation. Okay. Sorry for the mistakes, but we got there eventually.
Bye.
See you, everyone. So what? So you guys can't access that on the mixtape?
It's not just uploaded. It's just not uploaded.